Very good evening to all of you. On behalf of Relisys Medical Device Limited, I want to welcome you all in this evening and a heartfelt thanks to all our faculty and audience who have joined us today and taken out their valuable time from their busy schedule. Before we commence our today's agenda, let me take this opportunity to take you through the journey of Relisys. With the inspired vision of Dr. Abdul Kalam to make medical care affordable, the company became an independent entity under the name Relisys Medical Device Limited in 2007. The philosophy behind the project was to design, develop, manufacture, and market high-quality medical devices in cardiovascular range at most affordable price, thus helping needy patients in India and across the globe. Backed by technocrat and medical specialists, the name Relisys emerged from the reliable system, which ensure performance, efficacy, and safety to the patient. The strategic part adopted by the company was to ensure innovation and cutting-edge technology besides scale of production to achieve product and pricing advantage over competition. Today, we own clean and green state-of-the-art facility built in more than 12 acres of land, 160 lakh square feet of built-up area, clean room of more than 60,000 square feet of 10K, HVAC built-in management system built as per US FDA norms. Entire facility is certified at ISO 13485, DSR approved R&D laboratory, fully integrated end-to-end solution for manufacturing stent and catheter, and we are very proud to announce that we are one of the largest stent manufacturer in the world. So this is a small glance of our factory. With the vision of expansion in 2018, Relisys has acquired MatriX LLP, a CE mark company, as a part of the expansion plan. So this is our vast product range. We have drug-eluting stent like Premier Plus, Pristine Plus. We have bare metal stent like Oval C. We have balloon catheters like Pearl SCNC, angiographic diagnostic catheter Anand. CE mark days, we also do have Ensure ACE, guiding catheter Amber, guide extension catheter Access Guide, sizing catheter Quarch. Of course, pulmonary artery catheter Ipacath, transcatheter heart valve tricuspid, which is a trick valve, and transcatheter aortic valve, which is Vienna aortic valve. We do have Expanse, which is expandable introducer sheath, and of course, Relica as a microcatheter. This is our peripheral vascular product range. We have Coral, which is a peripheral diagnostic catheter, Advert B, which is a drug-coated PTA balloon catheter, Ingross, which is a PTA balloon catheter, Ingross HP, which is a high-pressure PTA balloon catheter, Perinity, which is a bare metal peripheral stent system, Peripact ACE, which is sirolimus eluting peripheral stent system. This is our new product launch. We are very proud to say we have recently launched our MatriX IVL, which is a coronary intervascular lithotripsy system. We have launched abdominal aortic stent graft, Metagraft AAA, thoracic stent graft, which is a Metagraft TAA, cutting balloon, Pearl CB, and coronary drug-coated balloon, Pearl DCB. So we are also equipped with our new product pipeline. So central venous catheters, hemodialysis catheter, cover stent, transcatheter valves, transcatheter pulmonary valve, transcatheter mitral valve, endovascular valve, and CTO recanalization device is about to launch. Today, we are proud to say we present in more than 70 countries across the globe. With the introduction of MatriX IVL, we are expanding our focus from innovation to education that empowers the outcome. And let me welcome you all in today, the inaugural episode of CUT COAT, the modern PCI, where we will be witness the evidence-based discussion on integrated CUT COAT strategy that transforming the outcome of coronary intervention. And today we have our facilitator of the evening, Dr. Puneet Verma. So he is a director of cardiology and structural heart specialist from ACE Heart and Cardiovascular Institute, Mohali. So there has been one challenge from Dr. Verma. So because of that, he couldn't able to join us as of now. So I would request the chairperson of this evening, Dr. Anant Raman sir. So he is the senior intervention cardiologist and director of Advanced Heart Failure Kaveri Hospital, Chennai. So I would request you, sir, to take us our session from here. The program is now and the platform is over to you, sir. Thank you.
Thank you, Madhavita, and sincere thanks to Relicis for initiating this program and for this inaugural program. The vision of Dr. Abdul Kalam is being made real by Relicis. Obviously, when we do PCIs, one of the major difficulties is the calcified lesions, and the devices we had so far are expensive or inaccessible to the Indian population. So under the Make in India, Relicis have made all the necessary sort of adjuncts that we need to do the PCI, especially in the complex situation in the calcified lesion safely, namely microcatheters, cutting balloons, and intravascular lithotripsy, and drug-coated balloons, as well as stents. So we have three sort of fantastic talks, which will showcase some of these products as well as how safe it is to use. I have used all of them. I will probably sort of during the discussion time tell you on how I felt in terms of using this comfort and the safety of the products. Because already we are running sort of 5 to 7 minutes late. We'll start with the first speaker. The first speaker obviously is going to talk about cutting balloon did wonders. And Dr. Aditya Goyal, Assistant Professor, Department of Cardiology, Mahatma Gandhi Hospital, Jaipur. Over to you, Dr. Aditya, to start the
Very good
proceedings.
evening to you, sir. Good evening to all of you. Is my screen visible? Hello.
Yeah, screen is visible. Make it slideshow.
Yes, sir.
Yeah, now it's visible.
Good
Yeah.
evening to all of you. So there was a case around 1 month back. He was 64-year-old male and diabetic. He presented to us with NSTEMI. So there was a very calcified lesion in distal left main, left main, ostial LAD. And so he was advised for CABG, but the patient refused for the same. So we had to do interventions in this patient. So here in the first picture, we can see the ostial left main is around 50% diseased. There was severe pressure damping. We use a 7 French catheter, EBU, as the guiding catheter. Distal left main was also 80% diseased here. Can you see the cursor also?
Yeah, we could see. Yeah.
Yeah. So distal left main was 80% disease. We can also see some amount of calcium here. And there was a calcium nodule also, which we found out on IVUS. So I will run a shoot now. Here we can see distal left main is 80% disease. It is highly calcified. Then proximal and mid LAD is also diffusely diseased. So we planned for this patient to take it to use some of the calcium modifications. So we planned for rotablation plus minus IVL for this patient. So we did a pre-PTCA IVUS for this patient. This is a bit fast pullback. We can see calcium, a huge amount of calcium here. We can see the nodule also here in distal left main. And then we can also see the ostium is diseased, severely diseased. So first we took 7 French EBU catheter. We crossed the lesion with a cyan blue wire, and then we exchanged with the rotablation wire with the help of microcatheter. And we did rotablation using 1.75 millimeter burr. This was the main calcium part at the distal left main and the ostial LAD. So, but as the IVL was kept in plus and minus situation, But after rotablation, there was not much improvement in the lesion. So we went ahead with IVL, and we also didn't had access to the higher size rotablation at that time. So we had access to IVL. So we did IVL with 3.5 into 12 balloon. We inflated it at 6 atmosphere, and we gave 5 to 6 cycles at this point at a distal left main and ostial LED, where there was a calcium nodule. And in there is not cranial view is not available, but in cranial view also the balloon expansion was not proper. There was a waste which was present in the balloon expansion. We can see here also that this is the shoot which was taken post IVL. We can see the calcium is still present here. There was not much effect by the IVL balloon. So we were in dilemma now what to do. These are the highest things available with us like Rota and IVL for calcium modifications. Then we tried using cutting balloon. Uh, as this was a cash patient also, so we had explained it not. We had explained not so much of expenses to this patient. So we used first we used a ox balloon, cutting balloon, which was some other brand, and it was not able to cross. But then we used in this patient Relicis, this pearl cutting balloon. You can see here 3.5 into 10 balloon was used, and which led to full expansion of the balloon, and there was no waste as it was seen earlier. You can clearly see here. This was the waste which earlier was very much in the IVL balloon or the pre-balloon. After using this balloon, the waste gone away. And after that, the shoot was also taken. Here also we can see there is a little bit more expansion of the lesion after using the cutting balloon. So it was a wonder for me because I always thought that cutting balloon is always inferior to Rota and IVL. But in this case, I think the crossability is also very good because of their blade design, I guess, because their blade is segmented blade is there. So normally cutting balloons have 3 blades, 1, 2, and 3. But here they have 6 blades. Like 3 blades are divided half, then it becomes 6. So I think because of this, the uh, it can reach more easily. However, it was a ox balloon, but still it did the work. So post I will post Rota, and then we use Zines Expedition, which is we put 3 stents here in the distal LED. It was 2.5 into 38 stent, and in proximal LED 3 into 28 and in from left main to ostial left main to LED, it was 3.5 into 28 stent. So this is the shoot which was done post stenting. We can see that the expansion is good. The ostium is covered. All the branches are there. Are TIMI free flow is there, and there is no dissection post stents, and no complications were there. L6 were also there was also TIMI free flow in L6 also. So we did a post PTCA IVAS also. We can see that there was no post stenting dissection. the stent is it was a long run, so we hurried it back because it might have taken much time. So there was good expansion of stent, good opposition of stent. Calcium was, however, there, but still it did good work. This was the IVS of left main stenting because the pullback ended. So we could see the stent is clearly covering the left main ostium. L6 was also seen in this IVS run that it's not, it pinched a little bit, but it's not compromised. There was also TME3 flow. There is no post stenting dissection and no other complications were there in this procedure. So it says that we use this rotatripsy and rotacut both in this patient. And normally we think that cutting balloon is inferior to all these things. But as there are many trials also, which also suggest that it is non-inferior to all these things like IVL and rota. It also works amazingly sometimes. And in this case also, we can see that it did wonders. So rotablator was used to break down the surface of the calcium. IVL, it cracked the deep calcium, and cutting balloon, it induced the fracture in calcium. So it made our work a lot easier, and the patient was discharged in a good condition after 1 day of stay. Thank you, sir.
Excellent. I think we have about 3 to 5 minutes for discussion. It's a fantastic case, and we'll probably have some sort of questions. Now, this IVS clearly showed there are multiple differential calciums. So there are some superficial calciums, some deep calcium in the proximal LAD, and the
Yes,
nodular calcium in the distal left main.
yes,
And most of the time we think probably we get away with one calcium modification. That is not the case. You need a combination of the calcium
yes,
modification
yes,
depending on the calcium distribution as well as the calcium thickness and nodule. And this
yes,
case clearly demonstrated, obviously, you have used all three sort of calcium modification techniques to the best of the results. So congratulations, that's exceptionally good result.
yes,
The other important aspect you showed is the imaging part as well as the assessment part. You just don't do one calcium modification and think you want to put a stent and come out, because that's where the trouble comes, or the
yes.
stent comes. I think
The
once you
stent won't have expanded so much if I think we haven't used all these things in this patient.
yeah. So I think the couple of points you mentioned during the presentation, the difference between this particular cutting balloon and the other commercially available cutting balloons.
Yes,
Obviously, the way the blades are arranged, the segmental blades, there's a 0.5 mm gap between the blades.
yes, yes.
They're
That helps
continuous.
for the easy access.
Yes. So it makes it more flexible as well as more
Applicability
compliant.
is good. Yes.
Now, the other important aspect with this particular cutting balloon is there is a working part. Any cutting balloon, there's a working part and a non-working part. So the working part is where the cutting happens, and the non-working part is the base of the blade.
Yes.
Now, the working part is only 0.13 in this balloon. So the chances of vessel injury or perforation is far less. You will get what you want. You will get the cut, but at the same time, you will not get an injury to the vessel. And it also makes the balloon profile better. So these are some of the added advantages. That's why the deliverability was good, even though you tried the other one. This delivery.
Both were ox balloons. So we naturally think that this is a good one, this is a good one. But we use both the same in this patient. So we came to know, yeah, the deliverability is much better.
Sure. Now, did you use the MatriX IVL in this case or the other competitor ones?
We use the translumina one, sir.
That's okay. Okay. So we'll discuss in the next case about the difference between the shock wave and this one, the IVL. There is a slight difference. We'll probably discuss in the next case and the advantages of how this is made. So clearly the advantage of the cutting balloon is clearly shown in this case and compared to the other competitors. And it's a much more compliant and deliverable and fantastic result. Any questions, any other points from the others who want to discuss? Okay, if there is no other questions, we'll have the next presentation and we'll have a final discussion. Stay with us, Aditya. We'll have a final discussion. Yeah. So the next presentation is bifurcation PCI with DCB. Shall we consider? Dr. Falgam, interventional cardiologist at Anandpur, Mork Hospital. Over to you, please.
Good evening, everyone. This is Dr. Falgun. Today I'm going to present a very brief case about the bifurcation PCI. Once again, I am going to share the screen. Is my screen visible, sir?
Yeah. So we can see the presentation.
And I'm audible as well, right?
Yeah, you are very well audible. Please.
Yes, sir.
Go.
Yeah, this is a 65-year-old lady. Her complaints are dyspnea and exertion class 2 only. And she basically came to me for a cardiac fitness for her bilateral TKR. And she was so desperate to walk her on her own. She's a diabetic and hypertensive as well. Coming to our ECG is showing T-wave inversions that triggered me further investigation. And I've got a 2D echo, which is showing the LAD territory hypokinesia and EF of 42% and with mild MR as well. We had scheduled the patient for a CAG because of her background to give a clearance. And then CAG was showing a single vessel disease with tight stenosis of mid LAD and ostial diagonal one. It is a Medina 011 kind of bifurcation, and it was a dual LAD physiology. Now what to do? Considering her desperation to get a surgery, non-cardiac surgery, can we proceed for the non-cardiac surgery without any intervention with the background of all this evidence of ischemia? Her desperation made me think twice what to do next. And the anesthetist also refused to take up for surgery as he was more concerned about the coronaries after seeing the angiogram report. And so, this was then we have taken up for, we convinced the patient regarding the PCI. And considering her desperation to go to a non-cardiac surgery, so I suggested a trial of DCB. You can see the LAD and diagonal it is supplying a similar kind of territory. So first I have engaged with JL. Later, a lady was wired with the BMW, and yeah, initially I pre-dilated using the 2 balloon, and later diagonal also wired. I used the same 2 balloon, NC balloon. Now I have considered doing the KBI using 2.5 16 PEL DCB in the LED, and 2.5 12 PEL DCB in diagonal simultaneously. So simultaneous kissing balloons. I did first dilatation for 60 seconds and the second dilatation for 30 seconds. So this is the final result. It is, I know that there is some disease is there near the diagonal ostium. But yeah, we have certain, we followed up the patient, and I kept the patient on DAPT, clopidogrel 75 milligrams, as well as aspirin 75 milligrams for one month. Later, patient was taken up for TKR, successfully underwent TKR. She remains asymptomatic even after 4 months of follow-up. So rationale to choose this strategy was patient's choice to undergo non-cardiac surgery and ease of withdrawing DAPT, as there is no metal left in situ. So Medina 011 was little tricky as the main vessel was disease-free. There was less chance for dissection, also the perforation. Proximal interaction of 2 DCBs need not create a proper concentric coverage. So this was the main concern why I have chosen this strategy. The main limitation was we couldn't able to do the imaging because of this was a scheme patient. So yeah, this was my case. Thank you very much.
No, excellent. I think it's a fantastic case, short and sweet, fantastic case, because now we are moving. We recently had this Stentless PCI Asia Pacific's first conference in Chennai, organized by my
Yes, sir.
close friend, Dr. Gopal Murugan. I was part of it, and we had a lot of discussions on this metalless or stentless PCI. There is growing evidence, definitely for mid to distal vessel, branch vessel, small vessel, side branch, and also now increasingly for the proximal vessels as well. But these high bleeding risk patients are patients who are going to need surgery within that kind of immediate period, 4 weeks or 6 weeks period. This is a very good option, reasonably good option. I think the couple of things you have highlighted, one is the balloon inflations for 30 seconds. That's very crucial. Imaging is crucial, but as you said, sometimes the financial constraints means you cannot do imaging. Ideally, I would, financial constraint was not there. I would have imaged, got the vessel size, pre-dilated, and pre-dilated with the NC balloon to the size of the vessel for 30 seconds, then DCB. Now, the DCB result has to be like, there should not be any deep medial dissections. The stenosis should be less than 50 and the recoil should be less than 30. I think you have achieved most of the primary endpoints with the DCB. I think image would have kind of added as a topping to that. But otherwise, the decision making was fantastic. That's what is necessary. Now, this patient can had the surgery already, knee surgery, and
Yes, sir.
also can have future intervention without any issues. There is no metal.
Yes.
Now, coming back to your case and coming back to the DCB, was there a specific reason why you had chosen the Pearl sort of DCB compared to the other competitors, or was
No,
it because
no
of the
particular
cost?
reason, sir. It was just a coincidental thing that
Yeah,
we had that PEL DCB in our armamentarium, so we used that. That's all. Nothing much.
sure. So I'll probably highlight some features of the sort of Pearl DCB compared to the other competitors. Now we have two drugs. We have the paclitaxel and we have the
Yes, sir.
sirolimus. Sirolimus is a difficult drug to hold on to anything. And as soon as you put it in the blood, even taking it and scraping the vessel, some of the drugs are lost. Now, the Pearl DCB is made such that it's flexible, the contact loss is less, and the second important thing is it is combined with ureas. That means urea is a natural agent. It's very highly hydrophilic. As soon as you come contact with the vessel wall, most of the drugs get into the intima, and most of the paclitaxel stays in the intima. That's where you want to act. So you have all the positive features. Now the clear evidence is coming up that the sirolimus part of the sort of DCBs, there is a late lumen loss, and the gain we get is also significantly less compared to the paclitaxel. So I think this Pearl is combining all these sort of positive features, and the outcomes looks good, and also the sizes as well. The 0.25 sizes are there so that you can appropriately size as well, and the lens are there, longer lens. So fantastic result. For these cases, I think bifurcation DCB is an acceptable choice as long as you don't create deep dissections. Very nicely done. And as you said, imaging because of cost, you could not do that. Any other points you want to add, Dr. Falcon, before we move on to the next case, or anybody else?
Sir, okay, sir. That's all, sir.
Any other panel members or others who want to add anything more to this? Good. So now we have seen the previous case of the cutting balloon, the MatriX, as well as the drug-coated balloon in this. Now we'll see all the three combination in the next case. I will invite Dr. Kamal Kanchina to present his next case, MatriX IVL, Pearl CB, and the DCB, all three, and modern PCI, how it's worked in a modern PCI, and how it's helpful in for Indian patients. Over to you, Kamal.
Hi, good evening, sir. Thank you for inviting me to the stage. So, can you see my screen, sir?
Yeah, make it slideshow and start from the first screen. I think you were in the third slide. Yeah.
Yes.
Go
Yes,
back.
sir.
Go back.
So, yes, sir.
So MatriX IVL, Pearl CB, and DCB. Yep. Okay.
Yeah. So, I'll be showcasing a case of a 71-year-old who had critical triple vessel disease, where we used all three modalities of calcium modification in a single case, and it was actually required for this case. So, coming to the angiogram, you can see the circumflex was diffusely diseased in the distal segment. It's a small vessel, and a lady was heavily calcified. You can see the calcium in the mid segment, and as well as in the with 90% stenosis. And RCA, you can see around 80% stenosis in the proximal RCA with heavily calcified vessel. So it's a triple vessel disease. Basically, we plan for we plan for a multivessel PCI. You can see the we did a pre-dilatation. You can see the underexpanded balloon in the medial AD. You can see this here in the here as well. In the arrow marks I've marked, it's a heavily underexpanded 2 mm SC balloon. So we thought it's heavily calcified. We did a IVUS run from the distal lady did show it was a heavily calcified 360-degree calcium in the medial AD. Can you see the IVUS run, sir?
Yeah, we can see. Just let it run.
Yeah. So it's a 360-degree calcium with more than 5 mm thickness in the middle AD. So coming to the left main. Yeah. So looking at this IVUS, we thought the only one thing we could do is use an IVL at this point in time. So we used the MatriX IVL. So MatriX IVL, this is the MatriX IVL. Usually, initially you can see the MatriX IVL struggling, but after that it did give away after a few shocks delivered, and this was the post IVL IVUS. You can see multiple cracks in the middle AD and the proximal AD as well, post the IVL. Sure. There's one crack here in the 11 o'clock, one in the 9 o'clock, and then 3 o'clock. The proximal AD, there's one crack in the 3 o'clock, 4 o'clock region, and then 7 o'clock here. So there is multiple cracks made with the MatriX IVL, excellent system. Yeah. So this is the IVL delivery mission. So post that, we stented the proximal to middle AD, and the distal AD we had to DCB. And this is the final result. The circumflex, we had to DCB since it's a diffusely diseased, a very poor landing zone. We ballooned the entire area, and this was the final result in the circumflex. We used a Pearl DCB, 2 into 40 mm. And the RCA, you can see the RCA, it's heavily calcified as well in the proximal RCA, and this is the IVUS of the RCA. Though this was also looking calcified, but there was no 360 calcium, I would say, the thin plate of calcium in the proximal RCA. I'll come to the segment directly. Sir. Yeah. So we use the Pearl cutting balloon. Left screen is the Pearl cutting balloon, and that's the final image after the cutting balloon. That's the final result. Yeah. Good stent position, good expansion as well. We're getting an MRA of around 9 to 10 in the proximal RCA. Yeah. Thank you. So,
excellent. Obviously, triple vessel disease with diffuse disease, both proximal and distal vessel diseases, and diffuse disease with variable calcifications, some superficial, some deep calcium, and also some nodular calcium in the sort of left main as well as the proximal RCA. So obviously the calcium modification, it has to be image guided. As you clearly shown, the first one, there is a dog boning with the balloon kind of not inflating fully. Now, you have used the sort of other IVL and you have used this IVL. How did you feel in terms of the deliverability of this IVL compared to the other IVL?
The deliverability was very much better. Second thing was it has a very faster reconciling time, I guess, sir. So other IVLs had almost 5 to 10 seconds of gap. Like I have to switch it off and switch it on. So this one had a very faster recovery time. So faster delivery time as well.
Yeah, so there's always been kind of concern when we are occluding the proximal vessel or even distal left main when we use IVL. There are 10 pulses and then another 10 seconds recovery. So it is 20 seconds of ischemia. And most patients do not tolerate it. And the welcoming thing with the MatriX IVL is you can still give 5 pulse, but obviously with the 10 pulse, and by the time you deflate and you are ready for the next inflation, within 3 seconds, that recovery period, it is ready for further inflation. And 4 atmospheres is more than enough. And the sizes also, that intermediate sizes allows you to use 1:1. So I was very pleased in terms of the shorter recovery period and reducing the ischemic time in the proximal vessel and giving exceptionally good result with good deliverability. So it's a very sort of welcoming thing, as well as the console showing the pulses left, the inflation time. So it was sort of welcoming. A lot of the things we missed with the other things has been added to this. So I was pleasantly surprised and pleased using this. For this particular case, obviously, the long DCB, for the mid vessel as well as the circumflex. They were long DCBs. And one of the difficulties we had in the past was delivering the long DCBs in these vessels. Again, the DCB was highly deliverable. So I felt it was exceptionally good. The 40 mm DCBs delivered well. Now the circumflex, if you show the final image of the circumflex, there were some dissections, and that is what we need. Now we understand that dissections are good when we are using a DCB PCI. So this is the beginning image, and the final image shows there are some dissections, but the IVS shows they were intimal and medial dissections. They are not deep medial. So these things will heal with a positive remodeling and will have a larger lumen. Especially when you have so many branches, marginal branches, you don't want to put a stent and occlude those branches. So for this particular case, I think the DCB with some dissections was a good result. So we'll do a check angiogram for this patient with check imaging after 90 days and then look at the results. But as such, this was better than a surgery for this particular patient. So we have seen the case showing the cutting balloon, the first case combining with rotablation as well as IVL. And the second one, the bifurcation with DCB alone. And this particular case combining all three modalities, the Pearl CB cutting balloon as well as the Pearl DCB as well as the MatriX IVL. Any other positive features, anything else you picked up, Kamal, from this case or from your kind of moving forward in terms of doing multi-vessel PCI, like a hybrid proximal vessel stenting and mid to distal vessel DCB? How was your experience and did it change your practice?
I work with you, sir. You should tell me, basically.
No, you are an individual operator because we are moving towards more of a hybrid PCI, like proximal vessel stenting and distal vessel DCB. Because when you look at the angiogram, you will think, oh, I'm going to put like 7-8 stents. But actually, you don't need to. This patient had only 2 stents, one proximal LAD and one proximal RCB, and then 3 DCBs. And that has given a fantastically good result with good lumen in the IVS. I'm pretty sure that we'll get a good lumen gain when we repeat the angio and IVS in future. That's moving forward. That is the thing. And in the recent stentless PCI, there is also growing evidence even for proximal vessels. If you have a good lesion modification, maybe DCB alone is enough. Even in left main bifurcations, we get a good result from left main to LAD and a DCB in the third. That's probably going to be the sort of future forward for these cases. Now, the major advantage, particularly for this MatriX IVL, I felt was one, it was deliverable. The balloon was semi-compliant. It was a deliverable balloon. And second thing, the pulses were very effective because the IVS showed there were good cracks. And third thing was the recovery time. It was very quick recovery time. So the ischemic period was less. So it's welcoming. As far as the DCBs goes, because of the urea as a natural polymer and the paclitaxel as the drug of choice, to get good drug retention, good drug delivery. There was a question in the chat box, I think, asking when should we use sirolimus coated balloons and when should we use paclitaxel coated balloons. Now, the issue with the sirolimus is as soon as it comes in contact with the blood, most of the drug is kind of left in the blood and the retention is less. If you have a lesion where you can quickly get in and inflate and deliver it, maybe yes, there is no difference between the sirolimus paclitaxel. But if you think the lesion is like this, some calcification is there, some difficulty is going to be there, I would probably use a paclitaxel coated one, especially like this one with the urea as a retention factor. There are some crystalline forms coming as well. So the technology is improving. At this point in time, the paclitaxel seems to be the drug of choice. Now, the second question is, what are the indications for DCB? The current kind of guideline recommended indication is mid to distal diffuse disease, small vessels, side branches. The proximal vessels, there is evidence is growing, but at this point in time, it is not a class 1 indication, the proximal vessel. So we have to be wary of that. When you do DCBs, it's very important to understand the good DCB procedure. You have to go back to the old angioplasty days. You have to get the vessel size right. You have to do the balloon angioplasty. During the stentless PCI, we did have good cases where a 30 seconds inflation is important with the NC balloon 1-to-1 before you put your drug-coated balloon. and then look for recoiling. If you get more than 30% recoiling or more than medial dissection or a flow limiting dissection like TIMI to flow, then stent should be done. Otherwise, DCB result should be good. So that is what is about the DCB. What the next question is where to use cutting balloon and scoring balloon. Now the scoring balloon, obviously, I rarely use it, especially given that now we have good cutting balloons. Cutting balloon is a controlled sort of orthogonal scoring in the vessel. That's what you want, especially when you want to do a DCB PCI. You don't want to have an uncontrolled dissection when you use a scoring or a non-compliant balloon. You pre-dilate to facilitate to take a cutting balloon. And once you are able to deliver a cutting balloon, it gives a good controlled cuts in the 3-4 orthogonal directions. And as I said, this blade is only 0.13. So the depth is going to be 0.13. So you will get the cuts, but you will not get injury to the vessel. So I prefer a cutting balloon anytime over the scoring balloon. That's what it is. And also before DCB, the cutting balloon sort of depth, little bit of intimal or medial dissections, as such helps the drug delivery and as such helps the long-term result. And the lumen gain you get, that's been well shown in the studies, you get a better lumen gain as well. So to do a good DCB PCI, do the angio, do the imaging, and score it with the cutting balloon, cut it with the cutting balloon, and then do the DCB 1:1. But make sure it is 1:1. I think there's some other question there. Is there any major precaution needed to take before using IVL? World is moving towards metal-less PCI. What is your take on this? The first question, is there any major precaution needed to take before using IVL? The IVL, this MatriX 1 is deliverable, but still you need to prepare to get the IVL delivered. So you need to pre-dilate very tight lesions or calcified. You pre-dilate with a 2 balloon or a 2 NC balloon. Then you take the IVL. If you're doing it in the left main or proximal vessels, shorter pulses can be given, 5 pulses, and then come down and then go back again. The ischemic recovery time in this is less, only 3 seconds. Otherwise, do not go over 4 atmospheres because it is not barotrauma you are trying to cause. You are delivering acoustic energy to cause cracks in the calcium. So one of the things is they say that I've tried the IVL, it was not working. So I went to 6 atmospheres, 12 atmospheres, then it worked. It doesn't work like that. Because there, when you go more than that, you are causing barotrauma. So IVL is meant for pulse delivery. It should be used as it is, 4 atmospheres, especially with the MatriX IVL. Now, the next question they asked is the metal-less PCI that we discussed already. Metal-less PCI is the future. At this point, there is evidence for mid to distal diffuse disease, for branch vessels, small vessels, all those things. And for ISR as well. For ISR as well, it's good. But for proximal vessels and the left mains, I think the evidence is growing, but it's better to wait before you go for a 100% use in the proximal vessels. For a high bleeding risk, like one of the cases was shown here, the LAD diagonal, where you have a compelling reason if the patient is high bleeding risk or if the patient is in need of surgery, life-saving surgery or orthopedic surgery, like the case we did 2 days ago. It was a left main circumflex ostial LAD, severe ISR. We did a cutting balloon. We did a non-compliant kissing balloon. Then we did DCB with good result. Those cases, I think DCB is the choice. Then patient can have the life-saving procedure. Then you can always re-image later on. And most of the time, the results will be good. If there is any issues, that time you can sort it out, either surgery or whatever is needed or further intervention. So these cases, the second case was a good example of that. How to choose a proper size of IVL? I'll probably image it. Pre-dilate with a 2 balloon to facilitate your imaging catheter and image it and take as per the vessel and lumen size. You don't need to go for media size because if you go for IVS and media size, you will oversize the IVL because you are not causing barotrauma. You want the acoustic pulses to work and cause the calcium crack. So if you have a vessel of 4 mm and a lumen of 2.5 and media is coming around 3.5, I would take a 3. That is enough IVL. Using one IVL for LAD and to left main, sometimes you take a bigger IVL and you'll cause trauma to the proximal or mid LAD. Don't do that. So it's based on the lumen size. You want to make contact to the lumen. That's what it is. The next question they asked is, there is some changes in the ECG at the time of IVL procedure. Is it normal? It is normal. There have been some very rare reports of this electrical sort of acoustic impulse or whatever it is interfering with this Oranti phenomenon like that. Very rare case reports. Otherwise, the ECG changes, more of ischemic ECG changes will happen, especially if you're doing proximal vessel as well as left main. You can give 5 pulse and come down and then give another 5 pulse. We routinely give phenylephrine bolus before inflating in a proximal vessel. We give 100 micrograms phenylephrine, then inflate. If it is a RCA, we also give atropine as well. So keep a good heart rate about 80, good blood pressure like 150, 160 before inflating the IVL. And by the time you finish the 10 seconds, the blood pressure will come down to like 100, 110. Then before the next pulse, give some more phenylephrine. So that helps in terms of the hemodynamics as well as, and that has worked well for us. So any other questions from any other sort of panel members or others?
Sir, I have a question.
Yeah.
Sir, when we do PTCA, when we do stents, after that, it's an indication to do IVUS post PTCA. So to check for the dissections, if there is any after the stent. But when we are doing the drug-coated balloons, we have some kind of same dissections there, but we are okay with it. We are not indicating that we should always do this IVUS after this to check for dissections and all.
Yeah. So now there is a big difference. When you do balloon dilatations, when you cause intimal and medial dissections, there is no metal there inside as a nidus for thrombus formation. When you put a stent and cause edge dissection with a stent, especially deep medial dissection with the stent edge, you have got a nidus. The metal is there and the thrombosis risk is high. That is one of the major issues. But once you cause these dissections, the recoiling is less unless you caused a bigger dissection and when there is a false lumen is filling with blood. That's why it's important. If you have some dissection in the IVUS or angiogram, wait for 3 to 5 minutes on the table. Look out for the recoiling. If the recoiling is more than 30%, if there is a lumen, reduction in the lumen, and if there is a reduction in flow, then it's better to stent. Otherwise, if the lumen is maintained, if the flow is maintained, if there is no recoil, then I think that's acceptable. We can accept a DCB result.
Okay, sir. So we should wait around 5 minutes after. If the section is there, we should wait for 3 to 4 minutes and look if it is going.
Yes, absolutely. Yeah. Okay. Yeah. Rather than in a hurry, I think that's very important. Yeah.
If it is okay in both the shoots, like last shoot and after 5 minutes, then nothing to be done. And if there is any flow limitation, then only further needed.
Absolutely, yeah. So that is what
and
has to be.
The same goes for drug-coated balloon also.
Yes, yes. Drug-coated balloon also, if you caused a medial dissection, you better wait for the 3 to 5 minutes on the table. You see a repeat image. 2 orthogonal images is very important. Because in one image, it might look less. But when you go to the other orthogonal image, the lumen restriction can be nicely seen. Okay. And that's very important. So the DCB PCI, if you see some dissection in the image or in the vessel, do an orthogonal image. If the orthogonal image shows the lumen loss is high and there is reduction in flow, then yes, you have to better put a stent. That's how it is. 2 orthogonal images.
Okay.
So I think we have come to time, 8:30. It's a fantastic inaugural sort of thing and good cases, exceptionally good cases to highlight the Pearl DCB, Pearl getting balloon and the MatriX IVL. I'll hand it over to Madhumita and the Relicis team to give the vote of thanks, and we welcome you for the next edition as well. Sincere thanks to all the speakers to take this time on a sort of late evening, and for all the attendees as well. And thanks to Relicis for this fantastic initiative.
Thank you, sir. Thank you so much. So on behalf of Relicis Medical Device, I want to extend our sincere thanks and gratitude to all our faculties and audience. And we are very happy to announce, sir, at this point of time, we were having a 550 plus live audience who are streaming, watching this streaming from Pan India, from the Cath Lab, or from individuals. So it is 550 plus audience was there with us. And again, a heartfelt thanks to all our audience and faculty, and we hope that this webinar could bring insightful and meaningful discussion on the table, and we will continue to do this academic series, and the next date of the program will be on 30th of May. And with this, let me conclude the session here. And once again, thank you and good night and happy weekend. Thank you. Thank you so much.